Hi, I am Shayla Bergman. I'm an associate professor at the Medical University of South Carolina with the Peds Hemonc Department or Hematology Oncology Department Division. I'm here to introduce you to two of my colleagues and myself who will be doing grand rounds this morning. We're going to talk about the advances in sickle cell disease and treatment. Our objectives today are to review the history of clinical trials involving the development of and use of hydroxyurea, to become familiar with new FDA-approved medications and current clinical trials running here at MUSC. And we'll discuss gene therapy, bone marrow transplant, and CRISPR options for sickle cell disease. We're going to begin with Dr. Sharon Jackson, followed by myself, and then Dr. Jennifer Jurasic will conclude our presentation today. Let me introduce you to Dr. Jackson. She completed her pediatric residency here at MUSC and joined the General Pediatrics Division, and where she organized the pilot studies for newborn screening for hemoglobinopathies. She was instrumental in establishing mandated statewide screening in 1987. And since 1990, Dr. Jackson has devoted her career and care to the patients with sickle cell disease. So I'll give you Dr. Sharon Jackson. Thank you.
Good morning. Dr. Bergman, thank you for the introduction. Let me get my slides. Can you see my screen?
Okay. Yes, we do.
Good, thank you. Good morning, and thank you for the introduction and the opportunity to talk about sickle cell disease. This is important historically for us in Charleston, and we have a large population of children with sickle cell, children and adults with sickle cell disease in our community. I don't have any disclosures, and I'll introduce you to a sickle cell, as you see on the screen, and introduce you to some patients who have sickle cell disease. It's unfortunate that these healthy children with sickle disease have a very shortened lifespan of about 40 years. Our job is to identify treatments and implement those treatments in order to decrease complications and prolong their lives as much as possible. Where is sickle cell? Where did it come from, and what is it? It's a single gene mutation that started in Central Africa about 3,000 years ago. And because of malaria, the parasite didn't survive in sickle cells. This allowed for the mutation to be spread from Africa by migration, but also through the transatlantic slave trade, which brought about 500,000 West Africans to Charleston, South Carolina. And as a result, we have a very, very high incidence of sickle cell trait and sickle cell disease in our low country. This slide shows us the pathophysiology of sickle hemoglobin. Notice in the center, hemoglobin S polymerizes under stressful situations like deoxygenation, acidosis, and dehydration. And as a result, on the left cascade, you'll see interactions with sickle cells, with the endothelium, with other white cells, with platelets, all creating a vasculitis type inflammatory reaction, and ultimately a vaso-occlusive effect, eventually causing pain that is the hallmark of sickle cell disease. The right cascade takes those same deformed red cells. They now have become sickle-shaped, because of the polymer formation of hemoglobin S, and they will have a shortened lifespan of about 2 weeks instead of 2 months. This hemolysis leads to jaundice and severe hemolytic anemia that contributes to the tissue hypoxia and organ damage that we know leads to ultimately a shortened lifespan. Now notice in the top right corner of this slide, we can see that a way to prevent polymer formation is to get rid of hemoglobin S by giving a blood transfusion where we're replacing S with hemoglobin A, or you can do a bone marrow transplant and get resolve the S, or gene therapy, which you'll hear about. The other opportunity to decrease polymer formation is by inducing formation of hemoglobin or production of hemoglobin F, or fetal hemoglobin. And this is what happens with hydroxyurea, which we've had experience with. And we're going to mention 2 new drugs that have been recently approved by FDA to impact the modulation of fetal hemoglobin. I want to mention about the STOP trial. This was a stroke prevention study in the early 1990s, one of the first randomized studies that we were participating in sickle disease. You may realize how important strokes are as a complication in sickle disease. The risk of stroke greater than 10% in our patients. And a method for identifying children at risk for strokes was developed. It's called the transcranial Doppler. And this ultrasound allows us to painlessly evaluate stroke risk and by doing and identifying high blood flow in children. The standard of care is now to do this TCD screening once a year in children with SS or S beta 0 thalassemia, starting at age 2 years and continuing until they're 16 years. And giving a blood transfusion if the child has demonstrated the abnormal TCD. Transfusions have then reduced the risk of a stroke developing. So this was one of the first trials to demonstrate a treatment using blood transfusions in children. Hydroxyurea is the other agent, a chemotherapeutic agent that was studied in the early 80s in adults. And then in the year 2000, we started the randomized trial Baby Hug study. And this is where we were able to demonstrate that we could induce fetal hemoglobin production even after the gene has been turned off. And we used it in babies as young as 9 months. They had we're on a daily regimen of about 15 milligrams per kilogram. And it was found that hydroxyurea would decrease vaso-occlusive crises, acute chest syndrome, increase fetal hemoglobin as high as 25 to 30%, decrease overall white cell count and inflammation, and increase total hemoglobin, thus reducing the anemia component. So the study was a randomized trial. About 96 children were on Hydrea. The other 97 patients had to receive placebo. And again, as it did in adults, it demonstrated decreased pain, decreased chest syndrome, and hospital stays. Unfortunately, there was no protection from the kidney damage and the spleen damage that we know are ongoing throughout a child's life and into adulthood. So this was concerning, but we still appreciate the benefits of hydroxyurea. The standard of care is now to offer hydroxyurea for all patients starting at 9 months with SS or S beta 0 thal, whether or not they've had any clinical symptoms, and that the benefits impacting their fetal hemoglobin, their anemia, are going to be beneficial throughout the child's life. The question then became, What about children who've had a stroke, who are already on monthly transfusions, but they're suffering from iron overload and their organs are being damaged from the iron? Could we use hydroxyurea to manage children who've had a stroke already? And this randomized trial was called SWITCH. Half the patients were on transfusions and X-Jade, an oral chelator. The other half randomized to hydroxyurea and phlebotomy. And unfortunately, in the hydroxyurea arm on the far right, you can see that 7 children developed new strokes while they were on hydroxyurea. Even one of our patients in our practice suffered a new stroke. So unfortunately, we were not able to safely use hydroxyurea as a treatment for children who had an established stroke. The study was terminated early because of these new strokes. There was no difference between the way we removed iron between the two groups. It was okay to use chelation or phlebotomy. And now the standard of care is, if you've had a stroke in the past, you should remain on chronic transfusions for a lifetime and take chelation or phlebotomy to manage the iron overload. And it's believed that the reason patients did not do well with hydrea is because they already had existing vasculopathy and significant vessel damage had already occurred, and the increase in fetal hemoglobin from hydrea was not enough to help overcome those findings. And finally, the next trial was, what about children whose TCD was abnormal? The recommendation was to start them on transfusions, but should they be on transfusions for a lifetime? Could we use hydroxyurea to prevent a future stroke in these children who were at risk? So this randomized trial was called TWITCH. The children were either on continued transfusions and X-Jade, or they started hydroxyurea, and this would have been after 4 years of continuous transfusions, then randomized in the study to be on hydroxyurea. And the results showed that hydrea was not inferior to transfusions. It wasn't necessarily better than transfusions. There were no new strokes in either group. However, there were three patients in each group who developed a transient ischemic attack during the study. The recommendation is that the clinician uses judgment to monitor how the TCD patterns are behaving when a patient is on hydroxyurea. These are children who've never had a stroke, and they have normal blood vessels when we look at their MR angiography. And this slide summarizes the studies that we've done, clinical trials involving hydroxyurea. The first one, though, the STOP study in stroke prevention, really establishes the prevalence of a TCD, how essential that is in screening our population for stroke risk. In 2000, the Baby Hug study demonstrated, the results of the study demonstrated decrease in VOC and acute chest. By 2005, that study started, SWITCH started. We weren't able to prevent a second stroke if you've already had a stroke when we tried to use hydroxyurea. We found out that hydrea will help prevent the first stroke if you have an abnormal TCD after an initial period of transfusion. And BMT, bone marrow transplants, established by 2010 that they would be a cure for sickle cell disease. It's interesting to note that there are no randomized trials comparing pain management, opiates, opioids, and nonsteroidals for sickle cell disease. So this is another area that needs investigation. I'll mention 3 new drugs. This first one is Endari. or L-glutamine, which was a randomized trial in children 5 years and older. This was a way to decrease polymer formation, decrease damage to the red cell by taking this powder form of glutamine daily, and it was shown to reduce the vaso-occlusive crises by 25% when we compared patients with Indari to patients on placebo. We are actively using Indari in children as young as 5 years, in addition to hydroxyurea. The second agent, and this one was approved in the fast track by FDA, is called Oxbryta or Voxelotor, and this was the HOPE trial by GBT. It involved patients 12 years and older, and it directly interferes with polymer formation, ultimately decreasing hemolysis, decreasing anemia, raising the total hemoglobin by 2 grams as quickly as 2 weeks of taking the treatment. It decreases bilirubin by 30%, retic count by 20%. The standard dose is a 500 milligram tablet, total 1,500 milligrams per day in patients who are 12 years and older. So we've encouraged our patients, many of them are already on hydroxyurea as they were in this study, and we add Oxbryta as an additional agent to minimize vaso-occlusive episodes. And finally, Adakveo is crizanlizumab. This is the SUSTAIN study, a randomized trial that was international involving 16-year-olds and older, a monoclonal antibody that is a p-selectin inhibitor. So this is not working directly on polymer formation, but rather this interrupts the interaction between platelets and red cells and sickle cells, platelets and white cells, and decreases the vaso-occlusive vasculitis component. This is an infusion, 5 milligrams per kilogram, infused over 30 minutes once a month. And the study showed a decrease in vaso-occlusive events in the patients who were treated over a 52-week course. So we are anxious to include patients on these new agents. This is the way that we can impact the organ damage and impact lifespan. Dr. Bergman will now present to us the clinical trials that are ongoing at MUSC. I have slides of references listed if you're interested. Thank you, Dr. Bergman.
Thank you, Sharon. Let me just pull my slides up and we'll go on. All right. So my name is Shayla Bergman. I'm an associate professor in our Division of Pediatric Hematology Oncology. I do benign hematology for pediatrics as well as sickle cell disease. I'd like to talk to you today about our clinical trials that we have open for pediatrics, young adults, and adult patients at MUSC currently. These are my disclosures. These are all having to do with more benign hematology topics, not sickle cell. We know that sickle cell disease is a complex pathophysiology that includes, pathological interactions between the sickled red blood cells, reticulocytes, neutrophils, platelets, different adhesion molecules in the vascular endothelium. And so this gives a whole bunch of different forms for the basis of new novel agents that are currently being developed to target cellular adhesion, different areas of inflammation, areas of oxidative injury, vascular tone, and then hemoglobin polymerization. Just a quick review of the different phases of how clinical trials develop. Before phase 1, you have your animal studies or your basic bench science research. Phase 1 involves looking at the safety and dosage levels determined by just a small group of healthy individuals. The purpose of this is to examine how a drug is metabolized, how it interacts with other medications, and then maybe how different doses can affect the body and side effects. Phase 2 leads you into a larger pool of participants. It's a more specific testing for specific conditions to also look at dosage and the efficacy of treatment. These participants are usually divided into two groups, one that is receiving the drug and then one that is receiving placebo, and these are often blinded studies. Phase 3, you've got a new and wider demographic selection to test long-term efficacy of the drug, as well as comparing it to other treatment options and medications. You want to make sure that it meets the needs or even exceeds the needs that you're looking for of either previous standards of treatment or current standards of treatment. This phase usually includes the largest number of participants. It's usually over multiple years to solidify the effectiveness of a drug. And at the conclusion of phase 3 studies is when the drug goes to the FDA for approval. If it's found to be effective, then usually it's offered to the public. You get your FDA approval, and then this leads into phase 4, or what we call extension studies. So after a treatment is approved, you'll put it on the market. The drug continues to be evaluated for side effects long-term, as well as safety and efficacy. So we have a number of trials in our queue that span all different phases. We have phase 1, phase 1/2, phase 3, and phase 4. I'm going to begin with our hibiscus trial. I'm really, really excited about this trial. This is from Pharma Therapeutics. It's looking at it's a phase 2/3 trial. It's an adaptive, randomized, placebo-controlled, double-blinded, multi-center trial that looks at the use of oral FT4202, which is actually a pyruvate kinase activator. We code this trial PRAISE. It's looking at, they know that pyruvate kinase activation can reduce the rate of sickle cell polymerization and possibly improve red blood cell membrane function, therefore reducing sickling and hemolysis. This is going to involve about 90 patients. It takes all genotypes. It's a large age span from 12 to 65 years. And the primary qualification is at least 2 vaso-occlusive crises in the last 12 months before enrollment. There are hemoglobin guidelines, and if you're on hydroxyurea, you can remain on hydroxyurea as long as your dosing is stable. So this was first announced at the ASH, or American Society of Hematology meeting in 2019. And just a little bit of basic science, remember that pyruvate kinase is an enzyme that is involved in the last step of glycolysis. So it looks at so it activates and catalyzes the transfer of a phosphate group of phosphoenolpyruvate to ADP. And so you're yielding a molecule of pyruvate and a molecule of ATP. So the two hypotheses involved in the use of this modifying agent in this study is, can PKR activation decrease 2,3-DPG, thus reducing polymerization of hemoglobin S and reducing sickling? And also, can it increase your ATP, thus promoting RBC repair, health, and reducing hemolysis? The great thing about this modifying agent is it's red blood cell specific, so it doesn't interact with any other types of cells. The next study I'd like to introduce you to is a phase 1/2 randomized double-blind placebo-controlled multi-center ascending dose study that's looking at the safety and pharmacokinetics of recombinant Adams TS13 in sickle cell disease for those patients who are at baseline health, and then there's an arm that looks at patients having a vaso-occlusive crisis. This is a study sponsored by Baxalta and Shire. We know that there's increasing evidence that suggests that elevated levels of von Willebrand's antigen and large von Willebrand multimers that are circulating can be associated with the development of VOC in sickle cell patients and thus complications with that. We also know that there's an existence of these ultra-large von Willebrand multimers in plasma and on vascular endothelium that indicates that there's a decrease in the Adams TS13. This is an enzyme that cleaves these ultra-large von Willebrand factor multimers to reduce their adhesiveness. So if you don't have enough of this enzyme, you have all these large multimers circulating, they're more adhesive, and they thus participate in a lot of cellular adhesion and thus even ultimately microthrombi development. So by increasing, the thought of this study is by increasing your concentration of plasma Adams TS13 with this study product labeled SHP655, you'll get a more physiologic balance and thus reduce adhesion and reduce vasoocclusion. It's an intravenous medication, and this is an older population in this study, currently 18 to 65. And this just looks at the basic science of the pathophysiologic model, where you've got microvascular thrombi that involve the von Willebrand factor and the Adams TS13 in sickle cell. There's several pathways that are affected. First, there's chronic inflammation that's associated with the release of cytokines that bind the Adams TS13, and this may inhibit the catalytic site where you've got functional deficiency of Adams 13. The cytokines can also stimulate the release of von Willebrand factor from endothelial cells, thus causing additional complications. You've also got, secondarily, got cell-free hemoglobin that's released when you have intravascular hemolysis that can both bind the Adams TS13 as well as the von Willebrand factor at cleaving sites, and therefore you're not getting specific cleaving. There is also endothelial activation that leads to the secretion of thromboplastin, which binds the von Willebrand certain A2, A3 domains, blocking access from the Adams 13 enzymatic cleavage, and then also leading to the release of neutrophil extracellular traps, which participates in oxidation and preventing proteolysis. So you've got these three pathways that give you the variable deficiency of this Adams 13 activity and its function, and thus increasing the release of von Willebrands from the endothelium. Together all give you this decreased susceptibility to cleavage, and all these conditions actually promote accumulation of these ultra-large hyperadhesive, hyperactive forms of von Willebrand that end up bridging complications between a dysfunctional endothelium with red blood cells and platelets and causing adhesion, as well as themselves aggregating together and promoting a formation of these platelet-rich microthrombi and small vessels, and kind of more of a microvascular thrombosis effect. So I'm really excited about this cellular pathway in this clinical trial that we've got involving this recombinant product. The next trial I'd like to show you is from Global Blood Therapeutics. Dr. Jackson mentioned the HOPE trial. This is a series with GBT that looks at an open label expanded access protocol for pediatric patients who don't have any alternative treatments, looking at Fluxator, which Dr. Jackson mentioned. This inhibits the polymerization of hemoglobin S in a 1-to-1 stereometric preferential way, and thus increases hemoglobin S oxygenation affinity and stabilization. So we're excited about this. This is an oral medication, as Sharon mentioned, in the age groups here of 4 to 11. Also with GBT, we have a phase 3 randomized double-blinded placebo-controlled trial with GBT 440 Fluxator that looks at sickle cell, the increased risk of stroke in the abnormal, in the patients with abnormal TCDs. And this is labeled HOPE Kids 2. So their primary objective is to look at, is Fluxator compared to placebo in children who have abnormal TCDs, can it make a difference and decrease their abnormal TCD flow velocity back into a normal range. There's going to be about 224 patients in this trial. It's a pretty long trial at 96 weeks of enrollment, age 2 to 15 years. We know our standard of care screening is 2 to 16. It's a randomized 1-to-1. And then, as Sharon mentioned, the dosing regimen is 1,500 per day, 1,500 milligrams per day for greater than 12. And then there's a dose equivalent for those less than 12. The next trial I'd like to show you is from Novartis. This is a prospective phase 2 open label single arm trial. It's multi-centered. It's a study that wants to look at the efficacy and safety of SEG-101, which is crizanlizumab that Dr. Jackson spoke of. This is looking at this medication in the use specifically for sickle cell patients who have priapism. Like I said, it's from Novartis. Crizanlizumab is the selective IgG2 kappa monoclonal antibody. It binds to P-selectin with a very high affinity, blocking its interaction with specific ligands, and thus hopefully reducing VOC, reducing adhesion, reducing aggregation, and hopefully decreasing priapism. So this will involve about 56 males enrolled in this trial, ages 16 and up. We know that P-selectin is expressed specifically in endothelial cells. It has interactions with platelets and leukocytes during inflammation and coagulation, and can even be key in atherosclerosis. The penis is really the only organ where there's a vascular bed that's exhibited a great increased expression in both P and E-selectin. And so that's why this may be relevant to sickle cell related priapism. And so hoping that this modifier might be able to prevent ischemic and non-ischemic occlusion disease related to sickle cell priapism episodes. We have a phase 2 multi-center open label study to look at the appropriate dosing of crizanlizumab with or without hydroxyurea use in sequential descending age groups. So this is where we're going to look at ages 6 months to 18 years, because we've already got approval at the older age groups. These are for any genotype, and really the main qualification is 1 VOC in the preceding 12 months. So we're excited about that. And then we've got some upcoming studies on deck involving hemopexin, which is really fascinating. And then, of course, DHA, or docosahexaenoic acid. Just a little bit about hemopexin. During hemolysis, hemoglobin and heme are released from the red blood cells, and this promotes oxidative stress, inflammation, and thrombosis. We know that. Plasma haptoglobin and hemopexin can actually scavenger-free hemoglobin and heme that's released, respectively. But this, when you've got a lot of hemolysis and a lot of cellular turnover, these both can be depleted in hemolytic states. So we think that haptoglobin and hemopexin supplementation can actually protect tissues, including vascular tissues, liver, and kidney. And so hopefully this will be a place where we can use this in relation to more protective mechanisms for hemolysis, the subsequent issues with hemolysis and sickle cell disease. Hemopexin also has a lot of different other cellular and modulating roles. It's important, like we talked about, in heme toxicity, but also in cytoprotection of cells. We think that it may be able to be a biomarker. It's also involved in immunity and activation of immunocellular processes, as well as extracellular oxidation. And then DHA. DHA is very important in sickle cell disease. We know that it can act as an antioxidant, decrease inflammation, decrease coagulation and adhesion, and also preserve cellular membrane integrity as well as fluidity. These are, we have our own benign hematology sickle cell research study coordinator group that I'm a part of and very proud to be. These are our study coordinators. From left to right, we have Brandy Day, Linda Wozniak, Cheryl Alston, and Crichton Milks. And then Karen Hawkins is our study coordinator manager. Thank you for your time. Thank you for your interest. And we're very, very excited to be involved in all of these clinical trials and these relationships here at MUSC. I'll introduce you to Dr. Jennifer Jurasic. She's a colleague of mine, associate professor here in the division, and she's going to talk to you about bone marrow transplant, gene therapy, and CRISPR therapy options with sickle cell patients.
Thank you. I'm happy to have the opportunity to talk about bone marrow transplant and gene therapy options for our patients with sickle cell disease today. Since I'm going last, I'm going to breeze through some of my initial background slides since my colleagues have covered the disease and the pathophysiology quite well. So we'll just go through these briefly, showing the pathophysiology. It is a disease that affects essentially all organ systems. And even though we are good at controlling the symptoms during childhood, we are not good at preventing the organ damage that is occurring throughout a patient's life when they have sickle cell disease. We've talked about the advances over the past 60 years, and my topic is going to focus on hematopoietic stem cell transplantation and gene therapy. We know life expectancy-wise that children born today with sickle cell disease have an average life expectancy of about 45 years. That has not changed in the past 30 years. We have seen a little bump right here where we have pushed mortality a little further out, and that was with the start of using penicillin prophylaxis during childhood. The first studies for bone marrow transplant were published in 1996. It was a multi-center reporting study where we looked at children with matched siblings who underwent bone marrow transplant. And what we learned from that first cohort of patients is that they have excellent survival, 93%, and excellent event-free survival, which means they're cured of their sickle cell disease, and that's at 85%. This was an updated series published in 2010 from the initial report in 1996. So right now, bone marrow transplant is the only cure for sickle cell disease. We think that gene therapy may potentially be curative, but it is not a therapy that has been studied for a long time. So what are the advances that we're making in BMT? I'm really pleased to say that just in the past month, we have amended our early transplant trial for children with a matched sibling, and now it can include patients who are asymptomatic. So having the disease itself and a matched sibling is enough of an indication to enroll on a clinical trial for curative therapy. I'm really excited. I met with a 17-month-old this past week, and we are hoping that his sibling will be a match. Despite excellent outcomes with bone marrow transplantation, there are still some barriers to bone marrow transplant for most patients with sickle cell disease who want to proceed with curative therapy. The biggest issues are that there are a lack of sibling donors, a lack of matched unrelated donors, and by the time teenagers are considered eligible for unrelated donor transplant with severe sickle cell disease, they are often starting to experience organ damage, which precludes them from being able to proceed with BMT. It's also very difficult for some of our families to commit to the 9 to 12 month time commitment to get safely through a bone marrow transplant. So I'm going to spend the rest of my time talking about gene therapy. Gene therapy is a group of therapies where the goal is to correct the beta globin that is sickle cell. When you do that, you correct the disease. You should not have any further organ damage from the sickled cells. There are several different approaches to getting the gene therapy into the patient's cells. And I'm going to go through those one by one, but if anybody's interested in more reading, this is an excellent paper that was published in 2016 talking about all of the potential forms of gene therapy to treat sickle cell disease. The benefits of gene therapy are that it is potentially a curative option for any patient who wants to proceed with curative therapy. There's no need to identify a donor because I can tell you after meeting with lots of families who would like to proceed with bone marrow transplant, we just haven't been able to identify appropriate donors for a lot of people who would like to proceed. When you use the patient's own cells to create the gene product, you have a reduced risk of infection, you have no risk of GVHD, you have a shorter follow-up time, and you have a reduced risk of graft failure. So starting with the first type of gene therapy, the one we're most familiar with is gene addition therapy, where you use a lentiviral vector to insert new genes directly into CD34 positive stem cells from the patient. This gene inserts throughout the genome, and when it's transcribed, it expresses the gene product. This is an overview of the gene therapy process. We've learned by transplanting several patients with autologous drug products that were created from bone marrow, that bone marrow is not the optimal source of stem cells for gene therapy. And since that time, we have switched all of our stem cell collection procedures to using peripheral blood stem cells collected by apheresis, and that gives us a very purified CD34 population to use to create the drug product. So we collect the cells here, we ship them to the centralized manufacturing site, which for this clinical trial happens to be in France. They are transduced with a BB305 lentiviral vector. Then they go through extensive testing to make sure they are safe to reinfuse into a patient. And after the testing is complete, the cells are frozen for clinical use. Once we receive the cells at MUSC, then we will put the patients through a busulfan-only myeloablative conditioning regimen and then infuse the drug product. And what we hope to see after transplant is that all of their red blood cells are transduced stem cells that make normal hemoglobin. This is a picture of normal hemoglobin. You have 2 alpha chains and 2 beta chains. And when the beta chain is modified with the gene product, it actually on hemoglobin variants tests as hemoglobin A. We followed the patients on trial for about 2 years, and because this is a very new therapy, they're then switched over to a long-term follow-up study, and we will follow these patients for 15 years after transplant. How does it work? This is data that was presented at the ASH meeting in 2019. And these are patients in group C who got the drug product created with peripheral blood stem cells. The purple lines represent individual patients and their episodes of vaso-occlusive crisis prior to their gene therapy treatment. And as you can see, after gene therapy, the rates of vaso-occlusive crisis and acute chest syndrome are reduced by 99%. So it's a very effective therapy when it works. We are going to be updating these data, but unfortunately they're proprietary and I can't share them right now. What is also really interesting in the recipients of the gene product is that the Bluebird company has looked at individual single cell Westerns to identify if each and every cell has gene modified hemoglobin. And what they see is that there is pancellular expression of the genetically modified hemoglobin. This is before treatment when some patients are transfused. Blue is their sickled cells, and the speckled pattern is the transgene. And you can see that it increases over time and the sickle percentage decreases over time. This is one of our patients who is in group C. This is her on the left, and 2 months after transplant with our gene therapy team and all of our colleagues in the sickle cell clinic who help us take care of these patients. And that was her at the end at her first 1-year follow-up appointment. Unfortunately, gene therapy is complicated, and in the group of patients who had bone marrow harvested, some of those patients have gone on to develop bone marrow problems. We have investigated these bone marrow problems to see if they are actually caused by the gene therapy. And it appears to be that the problems are caused by the myeloablative conditioning when the gene therapy treatment does not work. And unfortunately, for most of our group A patients, that is the case. So positives for gene addition: it works. There's long-term follow-up. The cells persist. The negatives are the risk for insertional mutagenesis, the exposure to chemotherapy, and infertility. Gene editing is a way to go in with molecular scissors, find the piece of DNA you want, introduce a strand break, and then either fix it with directed repair or non-directed repair. I don't have time to go through how CRISPR works, but one of the targets for CRISPR, which is the next phase of gene therapy, is going to be focused on fetal hemoglobin, which is gamma hemoglobin. As you remember with hemoglobin switching, your gamma goes down after birth and your beta goes up. What we know is that fetal hemoglobin is protective. So if we can interrupt the repressors, we can cause fetal hemoglobin to be produced again. And that is the goal of CRISPR gene therapy. There are 2 companies currently with clinical trials, Editas Medicine and CRISPR Therapeutics. We are going to be working with Editas Medicine. We were lucky enough to be selected as a site, so we will be offering this therapy in the next few months. Positives are that it appears to be relatively safe. Negatives are that it still requires chemotherapy preparation. Future directions for gene therapy, there are many. This is a nice summary slide talking about drug treatments, which are gene modifying, transplant, which is beneficial if we can find a donor, gene therapy studies that are underway, but the real goal is to get to in vivo gene therapy. I think this is a reasonable goal with the recent news media release saying Novartis and the Gates Foundation are going to collaborate to discover and develop an accessible in vivo gene therapy for sickle cell disease. And that's the dream. I hope that in vivo gene therapy treatments for sickle cell disease is developed during my lifetime as a readily available cure for all of our current and future patients. For now, I would just like to say thanks to our courageous patients for living with this disease and trying new therapies, and to our dedicated team who care for these patients throughout their lives. I would be happy to take any questions. Thank you for your attention.
Hi, everybody. It's Shayla again. Thank you for the opportunity. Thank you, Sharon. Thank you, Jennifer. We really enjoyed being able to show you all the bright, new, wonderful things for this patient population. We love taking care of these patients. They are a very important part of our lives. Please let us know if you have any questions, and if there are things afterwards or more you'd like to know, you can certainly always get in touch with us, email us, call us, page us. We'd be happy to talk to you.
This is Michelle. Shayla, Jen, Sharon, just a quick comment. I'm proud of you all. I think it's really tremendous to see how we've been able to advance over time and offer really excellent therapeutic and curative therapies for these patients. So thank you for your dedication. I think it's just a wonderful tribute.
Thank you. We love doing it.
Hi, I wanted to say that was just a fantastic overview of the entire field. Thank you for sharing that. I had a quick question about CRISPR. I was confused about the mutation editing. Did you say that it's trying to edit to try to restore, I guess, the expression of one of the proteins that normally is repressed? I didn't quite understand why they're not trying to go after the mutation itself, the primary defect.
The single point mutation, yes. I wish I would have had a little more time to go through the thought process in more depth. It is incredibly difficult to reproducibly target a single point mutation. So I think eventually the field may get there. There are numerous labs working on that, but it is much easier to disrupt the repressors that are suppressing fetal hemoglobin. And we've seen, like Dr. Jackson talked about, hydroxyurea increasing the fetal hemoglobin level to about 25%. The goal with CRISPR edited gene therapy is to get that hemoglobin F up into the 50 to 60% range. And when you do that, based on the location that gamma globin genes come first, so when you drive transcription down the gamma globin pathway, it actually decreases the production of sickle hemoglobin. Like, you increase fetal at the expense of sickle hemoglobin. So I'm sorry I didn't have more time to go through that in more depth, but thank you for the question.
Thanks for clarifying.
All right, I guess if there's no more questions, we will let you guys go. Happy Friday. We enjoyed it. Thank you for the opportunity.